Next, it's my really honor and pleasure to introduce our next honor speaker, Dr. Kuniyoshi Abumi. Dr. Abumi is a world-renowned deformity surgeon, especially in the area of cervical spine, and he's one of the pioneers for cervical pedicle screw fixation. And we're very honored and lucky to have you here this year to give us the talk. He's going to give us two talks. Today, the talk will be on salvage surgery on previously fused TL spine deformity. And then tomorrow, it will be his cervical deformity talk. Please welcome him. Yeah.
Good morning, the people of UCSF. Thank you. First, I would like to thank you very much for this invitation. It's a great honor for me to present my talk in front of the UCSF peoples. My first talk is salvage surgery for previously fused thoracic and lumbar spine deformities. I have nothing to disclose concerning this presentation. We, Hokkaido University spine team, started the spine deformity surgery maybe 60 years ago. This is the history of scoliosis surgery in Hokkaido University Hospital. Briefly, I talk. Firstly, we started turn-back cast with no instrumentation. But the correction is good, but it's very hard for the patient, and also very hard for the doctors. And after that, we introduced spinal instrumentation. The firstly, Harrington rod and Luque rod, Cottrell Dubois hook and rod system, and isolas system also we introduced. So development toward the direction of the segmental fixation. This is the Harrington rod. My senior doctor did surgery, but patient complained. This is a two-dimensional correction, and it required long fixation, and also rigid external support was required for the patient. And another problem is loss of such lumbar lordosis. And after that, Luque rod, Cottrell Dubois hook and rod system, isolas system developed, and increasing the spinal stability and the correction rate. And the anterior surgery also we introduced. Firstly, we started dwyer flexible cable, using a flexible cable, and the next Luque rod with flexible rod. The dwyer rod was the rigid flexible cable, but Luque rod was the rigid rod. After that, my boss, Professor Kaneda, started and two rigid rod system of the anterior surgery. So, but after 2000, some years, we started pedicle screw fixation, segmental pedicle screw fixation for thoracic and lumbar spine. This system provides high correction rate, good spinal balance, and patient need no external support. So I'd like to say this is a three-dimensional correction of three-dimensional deformity by modern instrumentation. But last 50 years, 60 years, we had several patients complaining of previously fused spinal deformities. Problem was residual deformity, aggravation of spinal balance, deformity progression in adjacent level, and the progression of canal stenosis adjacent to segments. Patients sometimes complained back pain, fatigue, walking, standing, or sitting disturbance by trunk imbalance. And some patients complained cosmetic or the mental issues. And sometimes patients complain spinal cord or nerve root symptoms. This was rare, but mostly by canal stenosis. This is a Harrington rod. You can see loss of lumbar lordosis. And Luque rod and Cottrell Dubois rod are the rigid rod, but sometimes three-dimensional correction was difficult, especially for rotational deformity. Correction of rotational deformity is difficult. Sometimes patients complained trunk imbalance like this. Probably this to center and right side show trunk imbalance, but must be fusion level was, we did error for fusion level. Fusion must be extended to be the sacrum for the neuromuscular scoliosis. Balanced spine is very important. Balanced spine provides less energy loss, supporting axial load, and no neck and back pain. And the C7 plumb line in standing position must be located on the center of the sacrum, S1 vertebral body. We have two tools for correction of previously fused spine deformities. One is spinal instrumentation, and the other is destabilization by spinal osteotomy to increase the correction rate. I'd like to speak a little bit about osteotomy. And we can, this is Professor Ames said, offering a progressive degree of destabilization, 3-grade deformity correction, 3-level osteotomy. And spinal cord, we have a 7-grade osteotomy, but usually we do anterior release of disc, vertebral body, anterior process resection. This is a grade 1, 3, or 4. And the Smith-Peterson osteotomy, this is very simple. We can do from posterior approach. But this osteotomy provides risk of iatrogenic glomerular stenosis by shortening of the posterior column. Pediatric subtract osteotomy is more safe to the nerve root. But we can do this only for C7 or lowers, C7 T1 and lowers. Vertebral column reduction is possible for this deformity correction, but this is not seldom indicated for deformity correction. PSO and BCR are possible by single posterior approach from C7 to L5. This is the fusion mass osteotomy. I think this is principally must be growing osteotomy. This is a shortening. This is so safe for nerve root, nerve tissue, and the direct bony contact provide high fusion rate. And the compression load must be applied on the convex side. We can see osteotomy line using the geographical position of the transverse process, and we can confirm pediculous location by lateral CR. The fusion mass osteotomy procedure, if patient had only posterior fused deformity, it's correctable by single posterior osteotomy. But if patient had posterior anterior fused deformity, because patient require circumferential osteotomy by single posterior approach is possible except 3 months C6. But second is by combined anterior posterior approach. Sometimes patient we need this combined approach. How about the aims of failed deformity correction? For balanced, if patient has a balanced deformity, main purpose of surgery is deformity correction. Osteotomy, you can do correction of deformity by osteotomy at the apex of the deformity. This is the lady with the Scheuermann kyphosis, previously operated anterior and posteriorly 4 times in Poland. I and Ohen Babacha J in New York did this surgery at 2006 at Accra, Ghana. We did anterior and posterior surgery by 1 anesthesia with hard and long surgery. And we did circumferential osteotomy at 7 levels at thoracic spine. Anterior and posterior fusion mass osteotomy we did. So, but correction is not complete, but must be sufficient. 90 degrees of kyphosis was corrected to 55 degrees. How about the aims of failed deformity correction for patients with lumbar imbalanced deformity with trunk shift? Main purpose is the restoration of balance. Osteotomy is effective near the caudal end of the deformity. This is a model of a previously fused scoliosis trunk imbalance. Patient complained trunk imbalance. And firstly, we did with osteotomy for correction of trunk imbalance at the lower level, usually in the lumbar spine. And the second stage, we also need osteotomy for correction of major curve and shoulder imbalance, usually in the thoracic spine. This is a case with idiopathic scoliosis. Correction and fixation was conducted at 11 years old, at high 11 years old, using quadruped instrumentation. You can see severe trunk imbalance. Firstly, I did metal removal. Metal removal of CD is not so easy. So we did two-stage surgery. Firstly, we did metal removal. In the second stage, you can see severe, you can see complete fusion mass from the upper thoracic spine down to the middle lumbar spine. And you can see also the retrogression of the pedicle by stress seal. So we cannot use the pedicle screw for the lumbar spine and the lower thoracic spine. So mostly we did Fuchs system. Firstly, I did the correction for spinal balance restoration at lumbar level, L1, 2, and L3, 4. And the second stage, I did 4-level osteotomy at the thoracic spine, 6, 7, down to T10, 11. So we got the sufficient trunk imbalance, and improvement of trunk imbalance. So patient had no fatigue, easy gait, the knee pain healed. And also patient can wear two-side reduced clothes. This is come from the improvement of trunk balance. This is a more severe case of the neuromuscular scoliosis. This boy had neuromuscular scoliosis. The trunk was shifted severely to the left side. The senior doctor did correction surgery at the thoracic and lumbar spine. Must be done to the sacrum. But trunk balance aggravated like the right side. So I did the two-stage surgery. Firstly, previously implant excision and fusion mass osteotomy at the lumbar segment. But the trunk imbalance was improved, but not sufficient. So we extended the fusion level out to the upper thoracic spine. And we did thoracic osteotomy and final correction like this. How about the deformity progression in adjacent segment? The deformity progression in adjacent segment is caused by progression of degenerative changes in adjacent level and or fracture of adjacent vertebra. Deformity correction and balance restoration must be done in coronal and sagittal plane. This is a case of so-called Charcot spine, neurogenic spinal arthropathy. This girl had a traffic accident. He had dislocation of T5, 6, and she fell to Asia A, complete paraplegia. We did T2, T9 fixation with Luke rod and sublaminar wiring. But the fixation is okay. But 30 years after, neurogenic spinal osteotomy developed at the lower adjacent level, especially T10 vertebral disrupted, very severely. So I did vertebral body replacement of T11, like BCR, and extension fixation to L2 by single postural approach. You can see good stabilization for this patient. This is another case. This case had the middle-aged lady. This patient underwent L2-5 brief for lumbar stenosis and instability. But kyphoscoliosis trunk imbalance developed. So we did closed wedge osteotomy at L1, 2, and open wedge osteotomy was done at L5, S level. Why I did open wedge? I afraid that the iatrogenic foraminal stenosis by shortening. So we did open wedge osteotomy for this patient in the lower level. So you can see fusion mastotomy versus postural approach at L12 and L53, and we extend the fusion level down to the S1. Sometimes patients complain the progression of canal stenosis or instability in adjacent segment. This patient underwent anterior-posterior scoliosis deformity correction. And 20 years after the surgery, patient complained of severe leg pain. You can see L5, 4, 5 instability and slipping of L4. Patient complained the severe leg pain at the right side. You can see foraminal stenosis of L4, 5. So we did foraminotomy for this patient at L4, 5, and fusion extended to the sacrum. But I'd like to say the global balance is very important. Flexibility of a compensatory curve must be considered to decide fixation range and degree of correction. Pelvis and the shoulder line must be horizontal. Too much correction of the main deformity in the thoracic spine may cause shoulder imbalance. C7 plumb line must be transferred on the S1 body in sagittal plane and on the center of the S1 in coronal plane. The key point of the correction surgery of previously fused spine deformity and imbalance. We have to consider which is more important in each case, deformity correction or balance restoration. We have not focused only on main deformity. Correction of main deformity may cause aggravation of global spinal balance or shoulder imbalance in some cases. Osteotomy at caudal end of fusion mass is effective for balance restoration. How about the problem in patient with molar alignment? In the left side, this lady had that TV kyphosis, very severe kyphosis. But spinal balance was not so bad in coronal and sagittal plane. So disability is this patient has no disability in daily life. This patient complains cosmetic problems. And the center and the right side, the picture show aggravation of spinal imbalance in sagittal plane and coronal plane. These patients complain difficulty in standing and walking. We need surgery for this patient. Balanced spine is important. Less energy loss supporting axial load, no neck and back pain, free use of upper extremity obtained by balanced spine. Like this. Thank you for your attention.
All right, Professor Abumi, great talk. Any questions from the audience? Okay. So I have a question for you. You know, Japan, when I visited there, have one of the longest life expectancies, in the world, and I've seen surgeons there treating, very much older patients than here. For example, they have 90-year-old with, kyphosis and scoliosis in the clinic, and their bone health is very poor. I just want to, ask you, in your experience, what are some things that you've done to kind of mitigate those risks, in terms of treating spinal deformity, older patients?
I think that osteoporosis is a very big problem, especially for the elder people, elder lady. In Japan, we can expect life over 90 years old. Sometimes patients survive at over 100 years. So osteoporosis is a very difficult problem for us. We have the next issue for the osteoporosis, struggle with the osteoporosis. And for example, my former professor, Kaida did anterior surgery very well. He sometimes did anterior scoliosis, surgical scoliosis or anterior instrumentation. Anterior instrumentation is very rigid. The correction rate was very good. But I am afraid anterior instrumentation in the thoracic spines sometimes may be possible to make the severe problem in the future. 90 years, 80 years, 90 years old, patient must be more osteoporotic. Rigid rod and screw in the anterior is very risky. Rigid rod is stable in the same position, but spine become more kyphotic. It's possible to dislodge the upper end of the instrumentation to come into the spinal canal. So I stopped the anterior instrumentation of the thoracic spine 20 years ago. I never do anterior thoracic instrumentation. And thoracic instrumentation is not so severe. It's easy to distract in the future. But the destruction of the anterior instrumentation in the old lady is very risky, very big surgery. So I stopped anterior thoracic instrumentation. Sacrolumbar and lumbar is okay.
Any other questions? All right. Well, thank you. Yeah.
Okay, thank you.